So welcome everybody to Chapter 2 of our Quality Improvement Plan or QIP Journey web series. This is brought to you by the Excellence Through Quality Improvement Project, known to many of you as E-QIP. Just go to the next slide. So I know many of you have used Zoom during March, but for those of you that haven't, we'll just go through a quick review of some of the functions. So in the bottom left-hand corner, you'll see a microphone icon as well as a video camera icon. If you click on either of those and you get the red line through it, it shows that your microphone is muted or your video is off. As Deb and I just mentioned, this session is being recorded, and we will be posting this webinar on our YouTube channel as well as our website. The way that it is being recorded, it doesn't show the gallery view, but if you are speaking, it will show your image. So please know it is your choice if you would like to show your video or not. Throughout the session, though, we do ask that you keep your microphone muted just to avoid having unintentional background noise going on while our presenters are speaking. We can just go to the next slide. Great. So in the bottom right-hand corner, you see a little chat bubble. You can use this function to ask questions throughout the webinar. Our good friend Chris Sullivan will be monitoring the chat, so do ask your questions, and we will take time to answer them as we go through today's session. So learning objectives for today are to understand the importance of data in your quality improvement plan, know the sources of data relative to your quality improvement plan, understand the different types of measures and how they align with your quality improvement plan, know methods to determine targets, and discuss keys to success. We do ask that you are attending today's session with an open mind and receptive to the learning of others. And I'm also going to pause here for just a moment, just to get a sense of where you are located in the province. So if you could indicate in the chat if you're in the north, east, west, central, or like myself, if you're located in Toronto. And Chris, if you could just keep an eye on responses there.
Well, it's coming through really fast, but my first impression would be equal distribution, maybe a little leaning more to the north would be my first impression, but looks like a good even distribution, Ash.
That's great. Thank you all for joining us from wherever you are located today. It's great to have you. Hey, Zara. It's good to see some familiar faces. Okay, if we could just go to the next slide. So we know that quality improvement is a priority, and this has been clearly outlined in plans from the Ministry of Health, the Centre of Excellence for Mental Health and Addiction, and Ontario Health. So there's a mandate to improve quality, implement innovative solutions, develop performance indicators to establish and monitor performance expectations, and Ontario Health's mandate to bring together a unified single team to execute the government strategy, oversee healthcare delivery, improve clinical guidance, and extend and strengthen quality and performance capacities across the continuum of care. Just go, I think this slide has a few little graphics here. And just advance again, so we can see how that all works together with your organization's strategic plans. So as healthcare providers, we have two roles in healthcare, providing care and improving care. And this comes to us from Quality by Design. Just go to the next slide. So a recap from our first Quality Improvement Journey Series, Chapter 1, which is available on our website if you didn't have an opportunity to attend live. Lots of practical tips that were presented by our good friend Chris Babcock. So start with what you have, know your program and service objectives. Use the quality domains. I'm not going to rhyme them off here, but they're 6 and they're very near and dear to us. And your strategic direction, operational goals to guide you through your process. Keep an eye out for what stands out to you. Leverage the knowledge of your colleagues. You're not alone in this process. In analyzing the data, it may or may not be an area for improvement, but you can help narrow your focus. board and leadership team can help you set priorities for QIP, and you can use this information to further develop your teams, to look at this as a leadership opportunity. And I believe, yes, we are happy to have Debbie Bang, who's the director and co-lead for the Quality Improvement Project, and one of our QI data coaches, Rishi Navar, and they will be presenting today's content to you today. And I believe I'm handing things over to Rishi.
Yes, thank you, Ash. And welcome everybody, and thank you for joining us on this morning for the very exciting topic. And it's great to see so many participants today to hear from us, and I'm happy to share my thoughts on to this, and I'm thankful to the E-QIP team for giving me this opportunity to share. So this is, oops. Oh. I wanted to show you this jump from my co-presenter today, Debbie's dog, who's trying to jump on, and so what the objective was to measure how far she made on goals, and that's what we want to do in our data collection, that how we can focus on what's measurable and what's counting. So that was the video. Unfortunately, I couldn't play that, so my apologies for that.
But they'll see it when we send them the slides.
Yeah, maybe I can try in the other way. Yeah. Oh yeah, this should work. Yeah. So this is how far she's jumping, and as Debbie can just recollect that she has progressed a lot, and I hope she's doing well today. She has been going through some skunk, so I hope she's feeling better. So the objective was to find out how far we can measure in our collection on data collection piece. So going into the next one, I wanted to give a overall touch point here, how data has come along in our everyday life. We are surrounded by data. We are swarmed with data, as we can see. It's a hot topic. Everybody is looking for our data, be it's a company or even our personal data. So there is very much relevance, and how can we apply that in your quality improvement journey, in your quality improvement plan? How can we make it more meaningful and the right amount of data? Because now we have so much information, but we need to find out what's valuable and what's meaningful. So that's the focus of this, how oil was back in the day, and everybody was rushing forward, and those who had access to that resource were the dominant players. And now in today's world, those who have access to this data are the key performers, key controllers. But we, within our agency, within our everyday working environment, we have access to all of this information from our clients, our programs and services. So how can we utilize that data in our performance activities, in our quality improvement plan? So that will be the focus here, just to make it more relevant. So this is a quote from Don Berwick, the founder of Institute of Healthcare Improvement in the States. Sum is not a number, soon is not a time. So we need to have a well-defined metric. We need to have actual data, or else without that will be just a vague number. So we don't need to, so when we are doing a quality improvement, we need to have actual evidence to justify our improvement efforts. So by talking all this, what is data actually? Like, I know we say a lot about data. So what is the basic definition of data? And in simple terms, it can be defined as an information, especially facts and numbers, collected to be examined, considered, and used to help decision making. And I want to emphasize on the last component, decision making, because otherwise, as I was saying earlier, data without that will not be held useful in our activities. We are currently going through a very difficult patch throughout the world. The global pandemic has taken place. And over 100 years ago, we had a similar pandemic that placed. So we have the data, but how we have used that in our decision making, was that useful to have that information before? So we all need data to understand how we are doing, whether individually as a service provider or an agency as a whole as well in our programs and services. And how can we use this information in our quality improvement? How do you make that, to make judgments, to answer questions, to monitor and improve, to support improvement efforts? And that can be from a variety of levels, right? From an individual client level, that data is being collected, a service level, from a program and an agency organization level, and as a meso level from a population level, be it's a local, municipal, or provincial level, or even a national, federal level. So that's where the data comes into play throughout this journey. This is the model that we use in our E-QIP model for improvement, and then the various foundations. And as you can see, the basic model for improvement stands on the three aims, triple aim. What are we trying to accomplish? How will we know that change is improvement? And what changes can be made that will result in improvement? And this is what we use in the quality improvement template that we will be sharing with you in the next little while. And I want to highlight that in all these areas, data plays a big role. We cannot start any improvement or any aim or any problem unless we get that background baseline data. So to come up with your problem and aim statement. And then we make those changes to plan those or make those changes. We need to understand the data. And when we are analyzing and looking at if those planned measures are making any improvements, so we need to also keep a track on that. So data plays a functional role in this component, and that's why I want to highlight that when you are developing your quality improvement plan. I want to stop here for a brief moment just for everybody to see this, because this is from a historic story, as you can say. And it starts with a rider who had a nail in the horse. And then the shoe was lost, and then the horse was lost, and then the rider was lost because of that. The battle was lost, and then ultimately the kingdom was lost. So the root cause was because of a small nail in the horseshoe, but it created such a big impact that ultimately the whole kingdom was lost. So I'm trying to bring that and how data applies here in this way. And even when you are making a quality improvement plan, and if you observe some erroneous values, some astronomical value, as we say, when we are plotting those data points, or if we are missing data for a certain period of time, and then we don't act on them, soon enough, that's going to play into a snowball effect. And then at the end, we won't be able to rectify those measures. So timely action, like measures from the data perspective, are very, very critical here. I wanted to give that highlight here, that don't ignore those missing values. Don't ignore those odd values that you may come across. They are telling you something, so pay attention to those when you are developing your plan. So after all this topic about talk of data, it comes into different forms. It's not just zeros and ones, as we all refer to. It's not just numbers. It comes in various forms. It can be quantitative and qualitative. There are two different basic types. We don't want to go into detail. We are doing another web series simultaneously along with this, which we will be coming across. So it's all about data literacy, where we will be focusing a lot on those topics. But just to give you a high overview of a quantitative aspect that we collect in terms of wait times or any other measures from a client perspective or from a program level. And then the qualitative piece, which plays a big role, which we don't pay attention as much, but that gives a valuable information from an individual client, how they are responding. And when you are trying to analyze based on certain themes, then you will come across where you want to focus on. And my colleague, as Ash mentioned, Chris Sullivan, who is here, and he will be showing you a live demonstration of OPOC portal, where you can see the different areas where you can see these different types of data, both the comments that the client users may be putting them, as well as the the numbers from their perception of care. So that gives a very good understanding of both the different types of data. And this plays a very big role in your quality improvement plan, how you are defining those measures, as we will see shortly. And this is the slide that I wanted to spend another few seconds here just to get you around that all that data without actions doesn't make any difference. So just to give you another OPOC level example of if we are looking at the question number 1, where the wait times are reasonable from a client perspective. And if we do a blitz and we get that data, how some at that period of time are functioning. And then when we have the data, we come up to understanding of a certain percentage of the population or our clients are facing that, that they may not be happy with their wait times or how they are perceiving. So that becomes the knowledge. And then based on that, we may do our root cause analysis. We may do all those investigations and brainstorming to come up with some action plan. And then we take into those decisions, which ultimately can change the data when we do the blitz again. So this is a circle and it's a loop that goes along. So there is it's a big interlink between how data and decisions play along. And as the definition said about decision making plays a big role in how we use data. So with all this, how do we go along developing our QIP and where do we start? But do we need very, very sophisticated systems, as I may have given you a wrong impression that, oh, now we need to go and start developing a big database. We need to go and collect all that kind of heavy data. But no, in quality improvement, we always say that start with what you have. We don't want to reinvent the wheel. So you use what you have. Good enough data is good enough data for a quality improvement project. And then what you have, different the good old client notes from paper charts, that's enough too. We don't need a sophisticated EMR or client management system. So stick with what you have to work on your current problem and identifying those measures. So you may be using OPOC, voluntary perception of care, or any other standardized tool. So that may be valuable to start with. That data is good enough for you to focus on. There are various engagement satisfaction scores that organizations are running their staff service, especially now within the COVID scenario. There things have changed a lot and how we are engaging with our staff as well as clients. So those survey results play a big role. The qualitative piece, as I was mentioning earlier. The common data set, the management information systems that most agencies have some kind of in a way, so that information can be valuable as well. Client record, as I was saying, and other data. So there are various and many reports I can imagine every agency and every organization has access to. So stick with what you have rather than creating a whole new area where you want to focus on. And health and safety incidents reports, many of organizations have that. Employee sick time, that's like one of the measures that we will be talking early in a later portion called balance measure. Whatever changes that we are making, there may be unintended consequences. So how that affects, so that data is valuable to play around and in your quality improvement plan and any other information that's valuable. So the idea of here will be stick to what you have in your first quality improvement plan as you go along in the journey. And I think this at this point I'm passing my baton to Debbie.
Thanks, Rishi. So good morning, everyone, and thanks to those who have their camera on. It's always nice to have an audience when you're speaking, so I have somebody to look at besides just Rishi. So thank you for putting your cameras on. In quality improvement, we tend to look at measurement in 3 different ways. So outcome measures, process measures, and balancing measures. And the outcome measure is ultimately going to convert into your aim. It's what you're trying to achieve, and it needs to be focused on the client. So thinking about how you want to improve things for the client. So it's typically the voice of the client. We want to reduce wait times. We want to increase the likelihood that clients are involved in their care planning. We want to provide programming that makes a difference for people's quality of life. Process measures align very nicely with change ideas. So in the model for improvement and in quality improvement, we figure out what the problem is, and then we figure out how to solve it. And that's always the challenge for people, is waiting to figure out how to solve it until they've really got to the root cause. And that's that has to do with all the brilliant people that are working on this, but it is always a little bit of a challenge to hold back with solutions until you really know what the root cause is. So process measures are how we measure each of those different components of our change ideas. And the balancing measure that Rishi talked about is those unintended consequences. So we may decrease the wait time, but we put an incredible burden on the staff that's not manageable. We may increase the likelihood that clients are involved in their care plans, and that may be a really positive intended consequence or outcome. So let me speak a little bit more about each of those. If you can go to the next slide, Rishi. So outcome measures, sometimes we refer to those as the big dots, or where we're trying to get to. And as I mentioned, they become aim statements down the way. So they really are the so what. Why are we delivering the service? What is it we're trying to do? What matters to the people who use our service? What is important to them? Some organization-specific ones, some are within our control and some are not. And some of those cross sectors. So we've been talking with the supportive housing group, and some of the pieces around access to their programming is a bigger system issue, as opposed to something that the organization can definitely have impact on. So some examples of an organization specific is timely, wait times, referral to the date that the service starts. You have some control over that once that referral is received by your area, and you can do something about that to make that better. A client-centered example might be that clients who strongly agree that they have a good overall experience. So part of what you're wanting to do is to find out from clients whether or not it was a good experience. And if it's not a good experience, figure out what you're going to do about that. The ones that are bigger, that cross, they're sort of cross sector, is that repeat visits to emergency department. As you can imagine, there's numerous factors that are contributing to clients coming back to the emergency department. And then, as I mentioned, the access to supportive housing. It's not something that many agencies have control over. They wait to get that referral. Next slide. So process measures. And when are these defined? So process measures really are about that change idea. So once you get to the point where you're working on your change ideas and you're going to test those change ideas, you need to know how to measure whether or not it actually made a difference. So here, let's just do a couple of examples here. And thank you, Alice, for making the example one a little bit stronger. So an outcome measure might be the average cleanliness score. So if we're talking about a program, a residential program, or a supportive housing program, so the standards, or what the change idea is, that the standard checklist for cleaning the building. So they're going to develop a checklist for making sure that the building is clean. The process measure then becomes the number of clients who rate the building cleanliness as high or very good. So we've asked the clients, they're telling us, we've got this checklist, we're making sure we're doing it, and now we have clients telling us whether or not we achieved what we were trying to achieve. Another example of an outcome measure would be wait time from referral to first day of service. And actually that's what matters to the client. Once they get referred to your service, they don't feel like they've been taken care of until they actually see somebody. That's their wait time. From the point at which they tell somebody they've got a problem to the point at which somebody starts to work on it with them. And that can be perceived as a very, very long time. And in some cases it is a very long time. So the change idea might be centralizing an intake process for referrals across programs. So it comes into your organization. Someone figures out which program of all of your different programs this client should go to, and they send that referral there. Try to make it so that clients aren't waiting in queue to figure out or get into the right line as to which program they should be going to. So the process measure might be the number of referrals that go through the centralized intake. How many did we actually deal with? That's how we would count whether or not we actually did that, as opposed to calling up, asking you to go to this particular program, and it may not be the right one. So centralizing that. Next slide. So outcome and process measures. So here's a real easy one, and this is one we can all probably relate to. And I notice on Zoom when we get to see faces that some people have done really, really well with this COVID thing, and their face has not changed a lot. And others of us, we have not done so well with the COVID thing, and our face is a little bit bigger than it used to be. So see where you are in that. I see some smiling faces. So an outcome measure might be weight loss. That's what we're trying to achieve. Our process measures become the number of calories we eat per day. And I don't want to talk about that. Or the minutes of exercise per week. So my youngest child told us my husband and I, if we increased our heart rate by 15 to 20 minutes every single day, he would take care of us when we're old. So we're very motivated to do that walk. So we did manage to do that again this morning. We're getting old bones and creaky ankles and all those things that go along with that. So another example that maybe is a little closer to the work that we do, outcome measure might be the number of clients who agree or strongly agree that they were involved in their treatment plan, something that's important to the people that we work with. So our process measures then become the clients who have a copy of their treatment plan in their own handwriting. Or another example might be the number of treatment plans in a chart that are actually signed by a client. So that's how we know that we actually achieved that outcome. Hopefully that's making sense for those faces I can see. Thanks, Darcy. Next slide. So balancing measures, and Rishi put in a teeter-totter for us because sometimes they're good and sometimes they're not so good. So it's the unintended consequence that could result from implementing your change ideas. And one example might be the number of critical incidents resulting in harm. We all want to reduce those. The idea for the change is an intervention to decrease medication errors. So if we're in a residential program and we're helping clients to have their medications, we want to reduce the medication errors. The balancing measure may be the number of incident reports for errors resulting from harm. So we've made a decision that we're going to reduce that harm, but as a result, we're having to do more paperwork for all the times that we actually did it. So just an example there. And another one might be, outcome measure might be the overall client experience. The idea is a proactive case manager contracts to determine if there's anything that they can do to help. So they get in touch with clients and ask whether or not there's anything they can do to help. Well, the potential outcome is increased client or staff workload. So an unintended consequence for a positive thing for the clients to receive. So again, it's that teeter-totter and it's balancing those pieces. Next slide. So just wanted to give you a little, and we will bring this slide forward throughout the series, and we have 5 more chapters to our book that we're going to be sharing with you over the next couple of months. And we're looking forward to having you join us. But this is about the quality improvement plan, which we hope that, that the mental health and addiction sector will move towards. We've done some practicing with this. We have 12 agencies so far, the very first pioneers who are completing this. And can you do the animation, Rishi? Can you check the next one? So the first thing is, what are we trying to accomplish? Aligns again with the model for improvement, and that becomes our aim statement or our outcome measure. Next one, how will we know if the change is an improvement? And those are the measures or the data that Rishi spoke so well about. And the last area, what changes can we make that will result in the improvements? And this is the fun stuff. This is when we start thinking really creatively and doing things differently. And that's where we put each of these things in the model for improvement. So you can see how it lines so nicely with the model for improvement. Very easy thing to do. Quality improvement plan done once a year, work on it the following year. So we're hoping that everyone will get involved in doing that. Next slide. So I'm just going to spend a couple of minutes on target setting. We're going to spend some more time on that on November 13th, which is our next webinar. And we specifically chose November 13th because we knew it was going to be a very lucky and fun day. So if you can join us on the 13th for our next one, but we'll talk some more about targets at that one. So why do you need to set a target? And I'd like to thank Noshiba for these slides. She is our measurement geek in a nice way, our guru. Brilliant mind when it comes to data. So when we think about target setting, what are we planning to improve? What area do we want to focus on? And what information do we need to do that? And your teams or coaches or any of you who have been involved in quality improvement know that baseline or what you used to do is very important. And if we can plot that on a lovely little run chart, and we'll talk about that some more as the chapters evolve, it's a way of sort of marking what's happening over time. And it's a way of telling us the story before we start to make some changes. There are normal variation in what we do. Some days we have 10 referrals that come to our organization, and some days we get none. And it's not only because that was Saturday or Sunday. Some days that's just what happens. That's normal variation for us. Or it might be seasonal. It might have to do with the weather. So I know children's services will often get all kinds of referrals at the beginning of the school year because things are not going so well for children in that classroom. And so a whole bunch of referrals all come in September, but that sort of wanes off as we get closer into the year and closer to May and June. So what direction are we trying to get to? Do we want our improvement to be an upward or an increase, or do we want it to be a downward? And whatever that improvement looks like in figuring that out. And what would reflect high quality care? And first of all, we think about it from an aspirational perspective. So if we were queen or king of the world and we wanted this to happen, what would it look like? What are our big goals, our aspirations? And then what's achievable? So we have to kind of balance those two. So our dreams and what we can actually do, but dream high, set high standards for yourself. Next one. And these are some of the ways to identify targets. And we'll again go into much more detail at the next session, but they can be used from a variety. So sometimes we can use benchmarking. So how do we compare to other organizations? How do we compare to services that are like us? What's the provincial average? And it'd be lovely if we had some of these numbers at our fingertips in the mental health and addiction sector, and we're working towards that. How do our peers perform, and who's really good at it and who's not so good at it, and what can I learn from each of those? Because we have lessons from both of those. Sometimes there's standards and lessons from literature or evidence-based research and studies that have been done, and those are a great place to get information. And Ontario Health has all kinds of standards, and many of those are mental health related and might be useful for you. And then plan change and performance using an absolute or a relative value. So I'm going to tease you with those words, absolute and relative, and then we're going to talk about those on November 13th. So join us. Can you do the animation? Rishi, I did that little orange thing that turns around. There you go. So join us for chapter 3, which is on November 13th, and we will learn some more about targets as well as more about counting. Next slide. And I'm handing it over to Chris.
Okay, before I do the live demo, just to let you know that the chat box is quiet, so that means people are really focused and engaged. So what I'm going to do now is share my screen. It's hopefully everything works. Here we go. Do I have Deb? Can you see my screen? Is it working?
Yes, we can.
Okay, great. So good afternoon. No, not still morning. Good morning, everybody. So I've been asked to do maybe a 10 minutes or less, a quick overview, a live demo and walkthrough of the OPOC reporting portal. Hopefully this is not the first time you're seeing this, but it might be the case where at your agency you may not have, you may not be the one who has access to the reporting portal. So this might give you a bit of an insight of to some of the things that can be seen and some of the things that can be generated inside the reporting portal. So this would be the home screen once people log in. And for the purposes of today's demonstration, I'm just going to pick, well, this is a fake website with, basically fake reports. And the 4 reports you see listed here are based on the different versions of the OPOC. So for this demonstration, I'm just going to pick the traditional standard OPOC. The OPOC version. So while that's loading up, what I'm going to do is a very quick review just to show everybody what you can sort of see and do inside the reporting portal. There is a more detailed OPOC webinar that would have been sent out to anybody inside an agency who needed and was granted access to the reporting portal. The reporting webinar, the recorded webinar, is being updated, and a new and updated version should be available sometime before the end of the year, and I'm sure everybody will be made aware of that when that happens. Additionally, there's a reporting navigation guide, reporting portal navigation guide, a document, a very colorful document that would have accompanied the email you would have received with logon credentials. That is there as sort of a desktop resource, a hand-on resource to with screenshots to remind everybody about navigating through the portal. So what I have here in front of you on the screen is again a fake agency, fake data. This is a place where the OPOC coaches, my colleagues and I, have access for the purposes of demonstrations. Maybe when we're visiting back in the pre-COVID days, visiting agencies in person and maybe do a bit of a demonstration with a couple of key members of the OPOC team right then and there. So just so you all know, what you're seeing is fake information, fake data, fake agency. So the first thing I want to draw your attention to are the tabs across the bottom there are 5 tabs: question, responses, demographics, comments, and additional helpful data. So what we're looking at right here is the first tab, the question responses. And as the name would suggest, it lists, it would display all of the questions in the OPOC, whatever version it is you're using. The screens look the same for the different versions that you might pull up. All the questions that are part of that particular version, the average score for that item, and the number of clients that actually responded to that particular question, whether it's strongly agree, all the way down the line to I'm just going to there we go, right down to the number of responses for that particular question, and what was the response rate for that particular question, if that's of interest to the team. The response rate, by the way, is calculated by, you can see where I'm pointing the cursor, 135, again, this is a fake agency, but imagine 135 clients answering question 1 out of 156 who completed and submitted the OPOC for a response rate of 86%, for example. And all the questions, of course, are grouped by domain, and you can scroll through and look at any question at any given time. For all the campaigns, for all the administrations that your agency has had or done since the beginning of time, they would be normally grouped together. But then I'll demonstrate the filters in a moment, where you can look at, February 2020, November 2020, November 2019, however the case might be, you can look at those exclusively. The next tab is client demographics, which I'm bringing up here, and this allows you to see, a breakdown of your respondents by gender, age, sexual orientation, first language, and this can be really helpful. This can be really helpful in determining if the respondents to the OPOC surveys that you hand out are a true representation of the client population that you serve. So in this fake example, you see here in table form and in graphic form, sort of the gender breakdown, age breakdown, and so on. And at first glance, you should be able to look at this and say, yeah, that's kind of a fair, spread of the clientele that we serve. As an extreme example, if you're an agency serving mostly young people or mostly senior people, you should not have people responding outside of the age categories that you serve, for example. But if you're a quote unquote sort of mainstream agency seeing people from ages 18 to 99, then you should have a typical age chart, for example. If it's skewed one way or the other, then it may be a cause for inquiry as to maybe certain people were not either provided or not completing the OPOC, and that's something that you might want to examine internally with your team and your OPOC coach. Population group is the last one as well. So the same comments apply. Do these represent a fair distribution of the clientele that we serve? Treatment demographics will be the next tab, and this lets you see a breakdown of your respondents in terms of their relationship to the client. Where it says not specified, that means that that the respondent was in fact the client, as opposed to a parent or caregiver or that kind of thing. So again, this is kind of an unrealistic representation, because again, it is a kind of a fake site, and when we complete OPOCs for the purposes of testing and demonstrating, we don't necessarily click all the categories necessarily. So it's a little bit of a fake example, but I think you get the idea of nonetheless of what can be displayed. Similarly, whether or not you can look at whether or not the respondent was either mandated to participate, and if it says not specified, then they volunteered to come to the agency and seek treatment. And finally, one can look at the timing of a client's journey through care. And this is really particularly important because when you administer OPOC, you may get very different responses from some clients. So if an agency were to only administer OPOC, let's say at discharge, and that could be weeks, months, perhaps even years after first entering the agency, clients may not really remember what it was like upon entry and those early days of being received and welcomed, or maybe even how long they waited and whether or not that was a reasonable amount of time. Conversely, if you only asked clients to fill out OPOC in the very early days, of course, there would be nothing for them to comment on about discharge, maybe the environment, the overall experience, and whether or not they would recommend or suggest the agency to a friend, for example. So all the more reason to make sure that OPOC is being administered, across the spectrum of journey. And if you pick a moment in time and sort of try to get everybody who comes through the door or comes through a particular program during a 2-week, 3-week, a month-long campaign, then you're much more likely to get a true representation of snapshot of all the clients that are involved in a particular time, rather than just on the way in or the way out, or exactly in the middle, for example. Moving on to the next tab, the comments tab. Many agencies will tell us that this is one of their quote-unquote favorite tabs, because this allows those OPOC portal users with power privileges. I'm just going to pause there and remind everybody there are 2 types of privileges, power and regular. Regular allows agency personnel to go in and look at the other tabs, except for this one. It doesn't allow them to access the raw data, and they only have access to a limited number of filters. Those who have power privileges, as the name would suggest, can see everything and have access to all the filters, and including the raw data. And those decisions are made inside the agency. The names come to us, the OPOC coaches, let's give this person power, let's give this person regular, and we submit the names accordingly, and the access is granted, within about a week's time or so. So the comment tab again allows for everyone with access to kind of see the open-ended comments, if you will, put some skin on the bones, the numerical bones that the other tabs show, and provides some quotable quotes, if you will, for agencies to look at and examine and share with board, staff, even public-facing documents. Many of the agencies I support will pick a quote, a favorable quote, and one that suggests that there's room for improvement for agency, and the agency can comment about their commitment to make a change in that particular area. So that is there, and as a popular one as well. The last tab is the additional helpful data tab. First glance, you can sort of see the overall agency's response rate to a particular campaign, for example. But just be mindful that this is really dependent upon whether or not care has been taken to make the right amount of OPOC keys and distribute the right amount of OPOC keys, and discard unused OPOC keys and things of that nature. So I encourage agencies on the line here who've looked at this number and wonder why the response rate is a certain number when they believe it to be another number, because it can be because too many OPOC keys were created, and those that were never used were not deleted, and so the denominator, if you will, can be higher than it really ought to be. But we encourage agencies not to get all bent up about response rates. What's important is that you're getting good quality usable data to inform your quality improvement decision making. The key areas of this particular tab are the priorities for the year. By default, the reporting portal and software embedded here will pick these 5 questions. But of course, any agency can pick any questions that they would like to track and follow. For example, questions 1, 12, 27, and 30, right? The 4 OPOC questions that are kind of part of this exercise. And so you can track these over time. You can compare them from, say, the spring campaign to the fall campaign and so on, and monitor your progress and see whether or not you're going in the direction you would like to go in. The questions are displayed, or the results are displayed in a couple of different formats here. And then another 2 very popular tables are the areas of excellence, there they are there, and the areas of improvement. And you can see there in the heading, this table is populated based on the top 5 average scores of strongly agree and agree. Conversely, areas of improvement, top 5 scores for disagree and strongly disagree. These end up being very popular, and many of the agencies I support kind of go here first, if you will, and kind of look at top 5, bottom 5, although we don't really call it bottom 5, but many agencies kind of use that language internally, and to see how they're doing on you know, the ones where they want to do well and keep doing well and maintain that. And the areas of improvement might end up being part of a quality improvement conversation, if that's where they believe that they should be doing stronger and want to do better. How's my time, Deb? Do I have a couple of minutes to talk about filters?
Yeah, I think you're good, Chris.
Okay.
Can I maybe, Chris, it's Alice. Can I maybe just share a couple of the comments in the comment box?
Yes, please, because I can't see them.
Yeah, and folks, just to clarify a couple of things, there was a comment around, just to clarify that, and you may have said this at the beginning, that what you're showing is the adult version, and that there is a child and youth OPOC. And so if folks if that access to the child and youth would be applicable to an agency to talk to their OPOC coach. And some admiration for the terminology of power user. You know, titles matter.
Okay.
And just also a commentary that the comments are very helpful. If you score low on discharge, as an example, you may get comments to help find possible causes. So I just wanted to share that if folks haven't been able to follow what's being said in the chat box.
I'll respond to the first comment about child and youth. I just want to make it clear, there is not a child and youth version. We have caregiver, we have crisis, we have supportive housing, and we have registered client and non-registered client. There is no OPOC version dedicated for youth, children and youth. So I'm sorry I don't have the comment in front of me, but I would encourage that person or agency to follow up with their particular OPOC coach for some clarification about that. I know the children's mental health sector used the OPOC as a pilot exercise last year, and in I think 4 particular programs across the 13 or so lead agencies, but there is no particular child version, if you will.
Sorry, I should have clarified. There was a previous statement to that, just talking about more options under 19 if you were working with children and youth. So thank you for that clarification.
Okay.
And so yeah, we sparked a couple more questions now. When was the child and youth version released? And so Chris, you've identified that that was a misinterpretation in the chat box. And just a question around how you identify your OPOC coach. If I don't know, Chris, you want to respond to that, or the other E-QIP team can respond to that?
If you don't know who your friendly neighborhood OPOC coach is, just remind everybody we're all neighborly and we're all friendly. Somebody at your agency, maybe your agency executive director, might know. If that question is coming from an agency leader, maybe the best thing is to contact me personally, chris.sullivan@camh.ca, and I'll do some quick figuring out and connect you to your respective OPOC coaches. But we have OPOC coaches all across the province, and we all have a district or LINs or group of agencies that we're responsible for, so we can certainly make the connection there. Okay, I just want to take a couple of minutes to talk about the filter. This is kind of really where the magic can really happen. You can see there's roughly 15 or so different filters. I won't go through them all, but just to give you an example of what you can do. So let's say, for example, in this fake agency with this fake data of 156 respondents, you wanted to maybe just look at what the females had to say and respond to the questions. So if you look at my cursor here on the left-hand side, the technique is basically to deselect everything and then choose, in this case, the gender you want to apply. Click OK, wait a couple of seconds, and what you get here is this. So you get 65 respondents. You can see here, oh, pardon me, let's go back. A little fast on the trigger there. Where are we? Yeah, here we go. So these would be the respondents from those who identified it as female. And maybe that matters, maybe that doesn't, but it's an opportunity to maybe make a case. If you wanted to look at females of a certain age category, then you would similarly pick, deselect, pick, let's say, 35 to 44, click OK. So I've got 2 filters applied, and here you go. You have 19 respondents that fit that particular category. So again, you may want to look at what people in that particular category have to say about whether or not the wait time was reasonable, whether or not the environment was appropriate, whether or not the overall experience was appropriate, whatever. So you can apply multiple filters. Just a word of caution, of course, the more filters you apply, the total number of responses will get really, really small and may not report at all. Agencies and hospitals that have multiple hundreds and even into the thousand of completed OPOCs in their database, would have a bit more leeway to apply multiple filters. But if you're an agency that still has maybe just a couple of hundred in your database, applying more than 2 or 3 filters, you may end up with a lot of empty cells, and then may become meaningless. But and then the other filters there are whether or not you want to look at where someone is in their particular journey, of course, the population group, reason for treatment, the first language, sexual orientation, and those kind of things, and service type, the kind of program, the kind of service they were receiving at your particular agency. So options are plentiful and of course you look at campaign by campaign. I should have mentioned that. This is I'm going to go down here. Pardon me. It's not showing up at the moment. I think I have to go down below, but nonetheless, you can look at November 2020 versus February 2020 if you want to look at that. So the filters are there to be used, and a new feature that's coming online now is where you can apply multiple filters once, and they will apply to all the tabs below. In this demonstration I'm showing you now, you would have to go through the process I just demonstrated with gender and age and apply that once again to client demographics, comments, and so on. But there's some coding happening behind the scenes by our data people, and the feature will be alive and be live any moment where, once you choose your filters, they will apply across the board to all the tabs. Maybe I should stop there and allow for some time for some more questions and for the closing as well.
Thanks, Chris.
Okay, I'm going to stop sharing and give it back.
So any questions for Chris? Anna's shaking her head no.
Okay, I see my email name is in the chat box. So again, if there's people out there who are uncertain who to reach out to from the Provincial System Support Program for OPOC coaching and support, please send me a quick note and I'll make sure you get connected today.
So I am the culprit for saying that there's a child and youth, and my apology for that. We have had so many discussions about a child and youth OPOC needed and what needs to go into place in order for that to happen and how we bring that sector into our work, that I just assume that there's this invisible tool that's already in place. And so my apologies for that, but there definitely is a huge interest and need for that. There's some infrastructure pieces that have to happen in order for that to come about. I still would encourage you to get in touch with your OPOC coaches though, because we need to continue to put pressure on. And French, is it available in French, Chris?
Yes, it is. All the versions are available in French and English. The registered version, the sort of traditional one, is also available in some other languages, principally for the GTA area, Mandarin, Cantonese, Punjab, maybe even Korean. I could be mistaken on that, but they are available. But those languages, it's not available in all languages. For example, just that one, but definitely French and English. A comment about the child and youth. This was pilot tested and tried to be written in plain language, typically a grade 6 reading comprehension level, but even that can be a challenge for some people. One of the key features and the obligations of agencies is to provide facilitation. So whether it's an adult or child and youth agency administering OPOC, they must provide facilitation to help with comprehension and flow and pace and so on. So that that is a reminder that we put out there to help clients navigate this.
And thanks, Chris. And what I really appreciate about the filters is that opportunity to think about equity in the work that we do and making sure that we're being equitable in our quality improvement. So each week or each time we're going to bring forward these keys to success when getting started, and we anticipate this fabulous document about how to do quality improvement plans at the end with all of our keys to success. So we've added this time about data and that link between using data to make decisions. So again, continue to be curious. What's not working so well? Ask questions. You're not in this by yourself. And thanks for Chris Babcock for giving us that. Words of wisdom, the use of data for decision making and looking at all the available data. And again, thank you to Chris for doing that, and Alice for walking us through the first chapter, including compliments and complaints. That remember, everything that counts can't be counted. So look at your qualitative data, the voices of your clients, and involve them in making the decisions about how you make things better. And I think I'm passing the next slide on to Ash to take us out.
Thanks so much, Deb. So our next chapter is going to be held on November 13th, as Deb mentioned, and you can see that there's a hyperlink to the registration on this slide. I'll also include this information in the follow-up email I'll be sending out if all goes well shortly after this webinar today. So objectives for the next webinar, we're going to go into detail on how to create a measurement plan, know how to complete measurement operational definitions, numerator and your denominator, know how to record measures on the QIP template, understand how to graphically display and interpret your data, know the pitfalls around data collection and analysis, and building on developing those keys to success we'll be adding to our list. So we hope that you're able to join us, and if not, that session will also be recorded and posted on our YouTube channel as well as our website. If we just go to the next slide. So recognizing that we just have a few minutes, were there any questions? Maybe if you could pop them in the chat, we will get to them just at the end. I just wanted to go through a few of our resources first. You can see links to documents that we referenced in today's webinar here. If we just go to the next slide. So these are some of the resources that you can use to stay connected to E-QIP and reinforce key QI learnings, as well as go back to webinars that you particularly liked or didn't have the chance to attend. I would really recommend checking out our website, www.equip.ca. You'll see this web series as well as our previous QI on the Fly web series, links to other offerings like our governance and leadership training, the ideas program, which is undergoing some modifications that are very exciting, and we'll be announcing some information about that shortly. Check out our newsletter. You can sign up for that through our website as well. And we do have our Twitter handle. If you could follow us there, we'll be sharing some great resources and information through our handle at equip_ON. And we do have our general community of practice that you can use to connect with other providers and also check out resources on there. And I think we have one more slide. So that's just a newsletter, and we'll be sending out one in November. Again, if you don't link on from this slide, you can go to our website and sign up for a distribution list. And we do have an evaluation survey for this webinar. We'd really love your feedback on how we can make these webinars more and more relevant, more and more pertinent to the work that you're doing. So do share your feedback with us, and we will use that to in the development of our future series. And I see some great comments coming in, so thank you so much for joining us today. And if you do have any questions, we just have about 2 minutes left of our time together today.
Thanks, Ash and Rishi and Chris for helping present today. Thanks, Hannah. You're such a sweetie. Oh, thanks, Chris. So any last thoughts? Any questions? Hopefully you know how to get in touch with us. If you do, we'd love to see you at the next session. Unless you're your motorcycle. Some people do that on 13th of, Friday the 13th.
Isn't it Port Dover? Is that where they all hang out?
Yeah.
Yeah, Port Dover. Yeah. Okay.
Yeah.
Are you going, Deb, this year? I guess you can't go this year.
No, I'm not going this year. Too big a crowd for me.
Oh, I do see there was a question there from Cameron. Chris, is OPOC data exportable?
As I came back, I realized as I came back in, I didn't demo the how do you extract the data. But yes, there's a button across the top ribbon. I don't know if I can bring it up or not. Oh yeah, here we go. Yes, we have 30 seconds to show that. Let me share screen. Okay, I'm gonna go back. Okay, am I sharing? Is it working?
Yep.
So right here where I'm pointing, see this here, export. There's a little button with an arrow pointing to the right. You were to click on that, and then here's what you get. You get this series of choices. Now, I cannot export the raw data here. It's just how it's set up. But if I wanted to export a report and create an Excel spreadsheet, you can see there's pre-selected report. I can choose what it is that I want. So which of the tabs across the bottom do I want? In this case, they're all highlighted. So let's just pick, I'm going to pick one, the questions one. I want a PDF, or do I want, PDF can be rather huge. So I would advise people not to choose that. Pick Excel, click OK, and you can see what's happening here. It's exporting to Excel. And it opens up Excel, and there it is. Okay. There it is right there. Just the tab that I chose, which was, you can see here in the bottom, question and responses. So this is where you can, you can then select, you can put this into a PowerPoint presentation. You can do whatever you want with it. You can't break the data. So if you manipulate stuff here, just know that you're not manipulating. It's still saved on the server. Hopefully everybody knows and understands that. You've just sort of pulled it out, and you can change colors, you can change font, you can do whatever you want here. Does that help?
Wording, Chris. I think we'll have to use that again. You can't break the data.
You can't break it. That's correct. So you can have all the fun you want with the filters. You won't break anything. Not to worry. So I'm going to stop. Hopefully that's clear enough, and I'll stop sharing now.
Thank you, everyone, for joining us. Enjoy the rest of your day.
Thank you.